week. This will be relatively easy after the lecture. And the reason for that, and why is this not turning on? Thank you. Okay. So we're going to talk about, where is everybody? What was that? Where is everybody? Oh, here comes one. Okay. Straggling in. Okay. So we're going to talk about narcotics. Okay, so narcotics are those scheduled drugs, right? 1 through 5, typically. And that 1 through 3, we don't use them. We're talking, this is the lecture 1 and 3. And it is on narcotics, non-narcotic analgesics, narcotic antagonists. So what reverses a narcotic? That would be the antagonist, okay? Sedatives are synonymous with hypnotics. They make you drowsy, they make you fall asleep. Anesthetics. Okay, there's typically 3 types of anesthesia. You get your tooth done, so that's a local. You go for a C-section, and you have to have a, what do they call that? Ladies in here that have had C-sections, epidural. They give you an epidural. So that is going to make half of your body where you can't feel it. And then there is an anesthetic, general anesthesia, where you're totally under, right? You need to be vented, put the tube down your throat because you can't even breathe for yourself. Okay, so that's general. So those are the 3 different types of anesthesia that we'll kind of get into. Stimulants, are as the name states. And then we're going to talk about musculoskeletal medications. They seem benign, but they're pretty heavy duty. And then we're going to talk about anti-Parkinson medication in this lecture. So, okay, become the change you wish to see in the world. I agree with that. Okay, so we're going to talk about not a narcotic, okay? Analgesics. Analgesics mean something that makes you feel better. Okay, salicylates is aspirin, so put equals aspirin. Okay, salicylic acid is aspirin. We've all had an aspirin, so we're going to really relate to this well. And then non-salicylates are like Tylenol, and we've all had Tylenol. So today's lecture is going to be pretty coast. Pain, you all know it's a 5th vital sign, right? We take their blood pressure, their pulse, their respirations, and their temperature, and then we ask, are you in any pain? Okay, now listen, legally you have to ask, are you in any pain? And then you need to get the location of where the pain is at and have them grade it, and typically it's 1 through 10, 0 being no pain at all, and 10 being the most excruciating pain the person has ever had. You give them the pain medication, and what is appropriate for the medication, you come back at that time and ask them again and reassess. How is that pain in your right arm, if that's what they stated, and what level is it? You have to do that legally. With your license, an aide does not have to do that legally, but you have to. And again, no one's going to read your charting, but if there's a problem, everyone's going to read your charting. And if you haven't come back and reassess, then you're sloppy and they're going to dig deep on you. Okay? So, Acute pain, chronic pain. Okay, acute pain is just that. It's happened, usually comes with something associated with it, a broken arm, a head injury. Yes.
I'm sorry to interrupt you, but could you make some time to explain the homework to us later?
Yeah, I'll do that.
Okay.
Thank you.
Sorry.
Good call. And we're getting into that 5th and 6th week where we're going to be talking about behavior modification. This is good, because obviously there's a test and there's points associated with it for your grade. But on Wednesday, hold me to this. I was going to carry it over today, but I had too much to carry over. I have a packet, and I got to tell you, I feel like most of you are reading. I really do. I feel good about that. But I do think there's probably, on any one week, up to 30% that is not reading. I can tell by the tests. I can tell by the homework. And I want to tell you, it is imperative that you read what I hand out to you. Why? Because you're going to do some reading, and then there's questions that you have to fill in the blank. Everything that you fill in the blank, you will see again on your state boards. Okay? The guy that wrote this pamphlet, that did everything, was very much involved, from the 60s, the 70s, the 80s, up until the 90s with your state boards. So I just want to lay that out and say, hold me to bringing it. I feel like, that's not going to be a problem. If I should happen to forget, hold me to it. And then I'm going to say to you, make sure you read that, because it is going to be critically important. Okay, so anyways, back to this. So acute pain. Acute pain is something's happened and boom. You can associate the pain with what happened. Maybe they went in for surgery. Well, you start cutting on someone, it's gonna, I'll never forget the first time I was in the operating room and heard the buzz saw go up. And I thought, is this, haven't we advanced further than this? That's what I thought. I felt like I was in a wood shop. Okay, so, when I saw that surgery, I was like, boy, you better believe one of my patients has pain, especially from surgery, I'm on it. And that should be one of your top priorities. Okay, so acute pain, mild to severe, short duration, 3 to 6 months, subsides when injury heals. Okay, so that's pretty straightforward. Chronic pain, okay, now listen. I always thought, oh my gosh, chronic pain, it's chronic. It must be worse than acute. Actually, it's not. Acute pain is the most severe pain, and that requires heavy duty ammunition, our narcotics. Chronic pain is something basically that the person has to learn to live with. And we typically give them NSAIDs, analgesics. So we give them Tylenol, mainly aspirin. So that is a big thing there. And then what I just mentioned are non-narcotic analgesics, the NSAIDs, of which aspirin is one of them, Tylenol is one of them. Actually, Tylenol is not. We're going to get to that. But relieve mild to moderate pain without losing consciousness and without causing physical dependency. I have never heard of anyone saying, oh, I got to get home and get my aspirin. It's not psychologically addicting, and it's not physiologically addicting. So kudos for them for that. Okay, now what does salicylates mean? It just means aspirin. Okay, acetylsalicylic acid is aspirin. Why do we give it? Whenever you see the word analgesic, right, that means to relieve pain. That's what an analgesic is. It's an antipyretic. That was one of our vocabulary words that we had in lab. Just means to reduce the fever. It's an antipyretic. I remember you asking me, Jacob, have you heard the word pyretic very often? And I said, no, I hear febrile and afebrile. And now that I'm thinking about it, because that question's kind of lingered in my mind, pyuretic you typically see in drug books. Okay, if it's a pyuretic or an antipyretic, it's usually in drug books. They use that term a lot in the PDR, the physician desk resource, or in your drug book. Okay, we know it's an anti-inflammatory. Okay, so what we call them is an NSAID, right? NSAID is and it's anti or non so I have it should be NAS. No, it is NSA, and it's non-steroidal anti anti-inflammatory drugs. Okay, or NSAIDs. Okay, so why are NSAIDs covered under narcotics, right? Narcotics is this big, powerful word, and NSAIDs are not. Well, NSAIDs are typically used for the chronic pain. And so that's where they come in. So what does aspirin do? Okay, now this is, you will see this, okay? You will see this on your state boards. This is what I want you to get right now. Aspirin kills platelets, okay? One platelet, I think it takes about 3 months to make another platelet for the one you just killed, okay, a platelet. You cannot have anyone going into surgery unless they have all their platelets on board, right? You don't want to cut into them and they can't clot. Okay, so the big thing with aspirin is no aspirin, and they say 14 days before surgery. I tell my loved ones 3 months. You know, have all those platelets on board. But for state board purposes, it's 14 days, okay? So, what does aspirin do? Oh, put a big star by this. Aspirin has the greatest anti-inflammatory effect. Wow. That's pretty heavy duty. We've already talked here that what makes you feel young is when you have no inflammation going. That the biggest culprit of aging is inflammation. Okay, so aspirin is anti-inflammatory, so it's gonna make you feel good. Okay, so what does it do? It inhibits prostaglandins. Prostaglandins is something that is in every single cell of your body. Different amounts in different cells. Women, prostaglandins are what cause menstrual cramps. Prostaglandins are thought to have a lot to do with signaling labor, contractions for labor. Okay? It dilates the peripheral blood vessels, so it cools the body. So there's that antipyretic effect that it's having. Okay, look at this. This is what we just talked about. Prolongs bleeding time by preventing platelet aggregation. It makes the platelets real slick and slippery, so literally they just slip off of each other and they lose their integrity by not clotting. Okay, so that's the big thing with aspirin. Aspirin, if I were to say one word to you on non-analgesic drugs, I would think aspirin, and I would think that it's the greatest anti-inflammatory, that you don't want to take it 14 days before surgery. That's what I would think. And antipyretic. Okay. So why do we use it? We all know this stuff. Mild to moderate pain, to reduce a fever, any inflammation. People that have arthritis are big on aspirin. They're popping it all the time, okay? Not good because of, this is, okay, another thing when you say aspirin, if you take aspirin for a long period of time, and I'm talking years, it will cause GI bleeding, where literally the person will come into the emergency room and they will throw up and blood will splatter on the walls, on the curtains, and drip everywhere because there's no platelets. Okay? It does decrease. Okay, now you guys know that aspirin comes in 81 milligrams. And then it comes in 325 milligrams. So a typical dose is 650 milligrams, right? 2 aspirin. But when you're taking it to help prevent a heart attack, you take the 81 milligrams. Sometimes they'll say I take a baby aspirin because it's real small. Or they'll say I take a child's Tylenol because it's 81 milligrams versus 325, 1 tablet. And what it does and how it works, how it prevents a MI, a myocardial infarction, okay? So MI, you guys know this. Myocardial infarction. We talked a little bit about a TIA. A TIA is a transient ischemic attack. Okay. A transient ischemic, okay, myocardial infarction, right? Your coronary arteries don't give your heart enough blood, you get pain, and if that pain continues, then the buildup, the amount of oxygen going to the heart is minimal, and the amount of CO2 leaving the heart is minimal. That means that there's going to be a buildup of lactic acid, and the person's going to feel like an elephant's on their chest. That's how men describe heart attacks. Women, we've talked about this, describe heart attacks. You know, I just feel a little achy. Just don't feel like myself. Okay, so they present 2 seriously different ways. One is like, whoa, I better get to their rescue, and the other is, well, are they? Aren't they? Are they? Aren't they? Meanwhile, their heart is losing, is getting infarcted further. So anyways, where I'm going, let me explain TIA. Transient, it comes and goes. Ischemic means that the tissue is dying, right? It's having a lack of oxygen. Attack. A TIA, we said that before a myocardial infarction, a person will have angina. Okay. And then before they have a stroke, and it's also known as a CVA, they will have a TIA. A TIA is telling you, and it's telling the person because they tell you the symptoms, and then it's up to you to decipher it. But they're telling you that it comes and goes. It's like, I feel the pain. Well, and how do they feel the pain? Okay, let's say that I'm having a TIA. Right there, I had a TIA, and then it left. And it can be that drastic, where the tongue and the mouth will droop, the person can't hold their arms out, that it affects their gait, and then all of a sudden it leaves them. That's a TIA. But then as it comes and starts happening more hopefully the person says, that was weird, I better seek out medical help. Because it's telling them that they're going to have a stroke. Strokes are no bueno, right? They are life-altering generally. Okay? A lot of times the person can't talk afterwards. They're cognitively impaired sometimes. They can't walk. A stroke is very devastating. You have to relearn a lot. But getting back to this aspirin thing, that it decreases the risk, how does it do that? Well, instead of causing a clot that's going to occlude the vessel more and cause a bigger heart attack and cause the TIA to last longer, well, the aspirin causes them to be real slick and they just float off of each other. And so therefore no clot forms, therefore these are minimized. Did that make sense to you? It was a long explanation, but I wanted to make sure that you understood what an MI was and a TIA. Yeah, Stephanie?
So we should start taking baby aspirin.
You know, I would say no to that, but I would say whenever there's an EMS out in the field and they describe, because they're in contact with the ER doctor to whatever facility they're going to take that person to, okay? That's the cool thing about calling for an ambulance, that an EMT will be there. They're on the phone, like literally with the doctor. And whenever there are signs and symptoms of a heart attack, the doctor will give the order, or it's a standard protocol to give the person a baby aspirin immediately because it mitigates the size of the heart attack. So your question is kind of there. I say if you've had, any angina, yeah, it might not be a bad idea. But I wouldn't do it I'm a nurse, I can't prescribe. Therefore I would say under your doctor's direction. It might not be bad for some people to take 81 milligrams a day, a tiny aspirin, a baby aspirin, a child aspirin. But it's for those group of people that are at risk for a heart attack, that maybe have a real strong family history. Maybe when they exercise, they get angina. But it's something to think about for some people. Have you ever heard of people just taking aspirin? With your background? Okay. Okay, yeah, and a lot of people do for those reasons. I think that if you're healthy and you're fine, don't do it. Give me the platelets. I want all my platelets because I'm more likely to, trip over my own feet. It's when someone's healthy. Okay, so we've all had GI upsets from taking aspirin on an empty stomach. Well, you just flip that over, take some milk, take some crackers, then take the aspirin. We've already talked about that it causes GI bleeding, especially for those people that are taking it for arthritis. Okay. Okay, and then this salicylicism, we're going to talk more about that, but it is toxicity of aspirin. Okay, it's when you've had too much aspirin and you're going to get dizziness, tetanus, the ringing in the ears, lassitude, and confusion. And did I put, okay, lassitude is impaired hearing, drowsiness, and sweating. No, excuse me, lassitude is drowsiness and sweating. So, salicylism is aspirin toxicity. These are the symptoms of aspirin toxicity. When someone tells you, I see a glow, I feel ringing in my ears, you stop everything and you figure out why. Okay, contraindications. So that means when we're definitely not going to give it, and then precautions. We're going to give it, but we're going to monitor them really closely. Okay, pregnancy and lactation, we're not going to give aspirin. Why? Because that woman has 40% more blood on board. And we need the platelets. When she goes into labor, if her uterus doesn't pull over, start to contract, she's going to bleed to death. Bleeding disorders. Well, that makes sense, right? If you're not clotting, you're in big trouble. Okay, now then there's this thing, you guys have probably all heard of it, especially those of you with children. It's called REYES, REYES, and it is deadly. Call it REYES syndrome. And it doesn't happen frequently, but it has been in the literature probably for about 20 years now, where when children take aspirin, they get REYES syndrome, and it can be deadly. So we don't give aspirin to little kids. Okay. So that's when we're definitely not going to give aspirin, okay? When we're going to give it, okay, you guys know that vitamin K, okay, initially when we're born, what makes vitamin K is E. coli. And so we have to generate a stool, and that shows that we have enough vitamin K now. Is that wild? And so then we can, if we're going to circumcise a little boy, we can circumcise him and not worry about him bleeding out. So if you have a vitamin K deficiency, you want to be careful about taking aspirin, because aspirin destroys platelets. Vitamin K is the beginning of the clotting cascade. If you don't have it, you're going to bleed out. Okay. And may increase risk of bleeding. We've been talking about that. And especially if you're on heparin, any type of heparin or warfarin. Why? Because those two are anticoagulants. So we're taking an anticoagulant, then we're taking aspirin. It's kind of a double whammy. Okay, some more precautions that we want to utilize is, okay, I talked about REYES syndrome, life-threatening, vomiting, lethargy, blindness, coma, death, associated with the use of Okay, this is another thing that I want to talk about. There's two, this is kind of a packed sentence. Aspirin is in a lot of things. It's not just you take the aspirin, the 325 milligrams, one tablet, and no, aspirin is in cough medicines. It's in ear medications. Aspirin and Tylenol is in a lot of different medications. It's even in some narcotics. Percodan, Percocet, Vicodin, all of those. So you have to be the one. Okay, now I gotta tell you, in here, it's going to be au contraire to what I'm saying right now. In nursing, 4 grams of not aspirin, but Tylenol can cause the person to go into liver failure in 24 hours. Is that wild? 4 grams. So Tylenol's the same. It's 325 milligrams per one tablet. You can also take real potent, both aspirin and Tylenol, in 500 milligrams. So if you take 2, instead of taking 650 milligrams, you're taking 1,000 milligrams. But, so 1,000 milligrams is 1 gram, right? And then if you're taking cough syrup or another narcotic that has Tylenol, we're talking about aspirin, but I'm going to use Tylenol. Do you see how it can really accumulate and get close to 4 grams in one day? You give 4 grams, you're throwing that person into liver failure. Is that wild? Just 4 grams. And that's in our medicine cabinet. So, Tylenol is, we all take it as kind of a casual drug, myself included, but it has heavy-duty consequences if someone ODs on Tylenol. Okay, what is the antidote for Tylenol? Say it.
Mucomist.
Very good. Very good. Mucomist, okay. And mucomist we learned as you know, it kills the mucus and it causes it to liquefy and come up. Okay, but anyways, back to this. This sentence is also associated with the use of medication containing aspirin or salicylates during a viral infection. During a virus, you do not want to give aspirin or Tylenol, especially aspirin. Okay, you do not, a viral you want to give it if the infection is being caused by bacteria and not a virus. We didn't hear too much of viruses before Corona, right? And now that's a viral infection. And so you want to stay away and you want to know what you have before you take. That's another reason why I say watch what you take. Because if it's viral, it can cause complications for you. This incurable disease, talking about Ray's syndrome, causes major brain damage, stealing the ability to perform many physical and cognitive, which is thinking skills. Okay, this is just showing this little girl who had it. Okay, nursing responsibilities. Okay, we've already talked about most of what's on here. Assess the type, onset of pain. Examine joints if you're using it for musculoskeletal. See if the joints are enlarged, if they're on both sides. Assess it. Do vital signs every 4 hours. Give with food or milk if it's going to cause a GI upset. Monitor for aspirin toxicity. Okay, here it is again. Decrease, I would say no use before and after surgery till healed. Okay, remember we said that aspirin can cause a GI bleed, and if you have emesis, it will be phenotypic emesis. You will literally throw up blood. If the person has digested that blood, it will show up in, if you guaiac their stool. This is the word guaiac right here. This, you guaiac a stool when it looks black and tarry, and black and tarry stool, the definition of that is melanin, M-E-L-E-N-A. Okay? If the person has a habituated aspirin and they are having a GI bleed but they're not throwing it up, you also want to check their stool for it. So if you have a patient, and typically when they get arthritis and their fingers are, real contractured, maybe, and that's the person that you really want to zero in on. If they have any GI upset, or any GI bleed, if they have any toxicity, and you want to check their stool. Okay, prothrombin time is how quickly you clot. So a PT, a PTT, and an INR are all checking your clotting time. And these are blood. You guys, am I being too verbose? Please tell me if I am. Am I talking too much? No, it's after a test, I get it. We're gonna stop fairly early. Okay, because I want to give you a sense of hope. Okay, because you didn't get it last week. It is 9:41. Do you want to take a break right now till 10 o'clock? Okay, let's take a break until 10 o'clock. And I'm thinking I can be done by 11. Okay, so if you'll kind of bear with me, take a good long break, get out, move around, please. And then we'll go bunker down and get out of here early, okay? Sound like a plan. Is that a heart on the side? Oh my gosh, that's way too cute. Do you have one on the other side?
No, money.
Oh.
Money go.
As you've been
ate.
You ate.
No. Dude, I think I have one for the coffee. No, it's just like.
I don't want to, but you can go home early.
I can. I was like, okay, stay in your pantry.
You don't want to give me this alone.
You stayed up late? Huh? You stayed up late? I was gonna stay.
Read teaching, that is on Canvas. This guy Fox is the inventor of all of this stuff. Okay, his brain generated all of this. Then there's a self-help test. And I get that I gave you the answers, but I want you to give it to me. So self-help skills and do practice test. So you're going to read the teaching self-help skills. You're going to do the practice test. You have the answers, but I want to see it, that you read it by now. You guys, and then you want to read in that one smaller book, chapter 7, 8, and 9. It's an easy read book, and it's very interesting. It's about the size of this, maybe a little smaller. You know which one I'm talking about? Yeah. Hold it up higher, will you, Martha? That's the one.
Hold on, let me see it real quick.
What chapter?
Oh yeah, I got you.
Yeah. What chapters?
7, 8, and 9. This is your homework that is due next Monday. Yeah. And then the cool thing is, the following week you have no homework. Okay? Yeah.
Nice.
I know, I hate to disappoint you. I really do. If you're having withdrawals, come and see me and I'll make it work. Okay. So getting back to nursing responsibilities, and what are we talking about? Aspirin. What's another word for aspirin? What? Oh, yes. Okay, I have, what's another word for aspirin? Let's finish that, and then I'll go to you. Benny? Yeah. Salicylic acid. Salicyliate acid.
It was just one question about this, like, what did you mean by 7, 8, and 9?
Oh, thank you very much. Can I see your book? Oh, it was you. You are going to read chapter 7, 8, and 9 in this book. And do the questions in there. And then you're going to do the self-help practice test, of which I already gave you the answers. But you're going to turn in the test to me because I want to see that you read them. And where I was going is that it is imperative that you are able to pick out the part of the question at this stage in the game that leads you to the right answer. The only way that, and this is science, okay, says that you need about, they say 4,000 to 6,000 test questions. I'm trying to give you as many test questions in this class so that you can get on it. Okay, if you are having get on it, meaning that you can start to identify really what the question is asking. I got to tell you, I'm this age, I've taken mega tests in nursing. Nursing tests are the same way. There's always two, and I got to tell you, this is not in the literature, this is a chemism. I go back and read the question and say to myself, now what are they asking? And I pick it out. And then as soon as I pick out what they're asking, I'm like, oh, that's the answer. Okay? Those questions, no one else on this campus except for nursing has questions like that. Right? It's always one answer, but not in our field. Okay, so you have to get used. And the only way you can get used to it is if you read a lot of those questions, If you are still having difficulty with this, call Walter Penniman, Dr. Penniman, and have a conversation with him and dialogue it. And see, if that helps. It can't hurt to try for sure.
Where's the self-help test on here?
It is on Canvas. Good question, Stephanie.
We print it out and turn it
or do we turn it on Canvas?
You can turn it in on Canvas to me. But send it to my school email, not to the Canvas email, everyone. Okay, everyone knows that, right? Because I've said that like 5 times. Send it to my school email, not Canvas email.
And that's for, right?
And that goes for your study guide, correct. And then we're going to count this self-help test as a study guide. Okay? Yes.
You mean the package?
Okay, obviously I'm not making myself clear.
So we're
Okay.
still doing this on the study. So we're lost.
Okay, it must be me, not you. Okay. Look at your workbook. Go to week 5. Okay, it says read effective behavioral programming, which is, can I steal your stuff? You're probably never going to sit here again, Martha. Read this and answer questions in the behavior modification module. Okay, so you're going to read this and answer the questions in there. Okay, pretty thick. Then you are going to read the teaching self-help skills, which is in Canvas. And you are going to do the practice test, which is in Canvas. I give you the answers, but I still want it. The reason is I want to see that you are getting flooded with more board-like questions. That you can read it and go, once you know the answer, you're like, oh, now why is that the answer? Go back to the question and see if you can pick out the phrase or the word that led you to that answer. And then I want you to read, and it's called Developing Staff Competencies. Okay, it has a longer title, but this is DSC. I want you to read chapters 7, 8, and 9. This is honestly easy reading. And it's nice reading, and it kind of gives you more of a flavor for what's going on. We are now, yes, this class is a lot of pharmacology. But we're going to part from pharmacology for a couple weeks. We're going to come back to it, and I'm sorry. But we are going to come back to the pharmacology, but we're going to start doing the womb to the tomb, developmental problems, difficulties. Okay, so, and it's good to have some history behind it. You know, I want you to know I lived through that history. I was a little child in the 60s with a severely disabled man who couldn't find a job, who was super bright, could do calculus in his brain, but because he looked so grotesque, could not get a job. That affected me my whole life. Okay, and it's so cool. I remember I worked at Menifee Hospital, and everyone was like, "Oh my gosh, these DA, disability laws, what a pain!" And I'm like, "Bring it on, bring it on! I love it." We need to have that segment of our society that had no voice have a voice, and part of that voice is going to be through you. Part of that voice is being in conversations with friends and either have them scoff it or feel like they had a hard life, and I would be like, let me tell you what a hard life is. Let me tell you about disabilities. Okay, so it's a cool book. I liked it. I really got a lot out of it. But anyways, back to this. Any questions on homework? I feel like I was super clear, but if you have a question, I want to entertain it.
Can you show us how to get there on Canvas?
Yes.
Thank you.
And so do you want us to answer every single question in this?
Yeah.
Like the 400 questions?
Yes. If that is too much, I will accept the homework. I'm not going to tell you this, but I'm going to accept the homework the following Monday. Okay? I want you to be thoughtful about this. I am not about you copying. I am about you learning. And if you don't learn, you're going to have a rude awakening one day.
So the homework is due the 26th?
You know what? If that will make you happy, I am happy to have it due the week of the week 7, that Monday. I will be more clear on that after I look at it. I don't have a calendar in front of me, okay? Okay, wait a second, I can tell you that, but it will take me a minute to find it in my trusty book. I will find it. Okay, it's not coming to me right now. I've got too much, my little fingers. Okay, I will, more to come on that tomorrow, okay, in the morning, yes.
But this is all on the test we're taking Monday, right? This packet is just the test.
Okay, that's why I didn't want to hand it out. No, the test that you're taking on this coming Monday is going to be on analgesics, antagonists, narcotics and sedatives, and Parkinson's.
Okay.
So that's gonna be the test on Monday. People were asking after I explained it, so therefore I felt like maybe it was me, since people were asking me the same question of what I had just explained. And I gotta tell you, I know that none of us in here are good communicators like we've stated before. None of us are. We think we are, but we're not. Because you and I are very direct people. You know, that's why we're weird with our groups that we went to high school and college and with, okay? Am I making myself clear? Where you got these big smiles, a lot of you, because you already know what I'm talking about. So, because I know I'm not a good communicator and people were asking me the same question, I thought, oh, I better stop and make this really clear. So I went to my office. I wasn't gonna hand this out until Wednesday. But I went to my office and I brought it, and now we're having the conversation. And I wanna finish it to show you where you go to Canvas, okay? Is everyone
Yes.
tracking with me?
Yes.
Okay, cool. Okay, okay, so I am gonna go to Chrome, and I have been told that that is the easiest to get to for Canvas. So I just put in SBVC, I see login, okay, so then I go to quick login, I come here, I go to Canvas. I've already told them all of my information, so I can just hit login. This says, you know, I won't abuse it. Okay, so now I am in, I don't want my clinical, I want the lecture part, so I'm gonna go here. And I am going to go to week 5. Here's 1, 2, 3, 4. Okay, this is really week 6, so excuse me. So here is everything, and you asked me, here's the self-teaching PDF. So you're gonna read this. I'm gonna download it. You're gonna read this, it's right in here. It's quite a bit. I mean, this is a 17-unit class, what can I say? So you're gonna read all of this. And then you are going to take the test. Which is the self-help pre-test. And look at right here are the answers. So here's the test. Does everyone feel comfortable with this? And here's the answers. Cool. I'm glad we did that. Thank you for allowing me to do that. Okay? So now the question outstanding is, when are these due? I will tell you that tomorrow, okay? I need to look. Originally I was gonna get you guys going on it, and I'm kind of getting a little resistance, and so I'm gonna give you an added week to do it. Okay, you can turn it in. I'll give you 2 dates. The reason why I'm doing that, and I want to say this again for the 3rd time because it's very important. This is a lot what you are going to do the rest of your career. You need to learn it. Here's your opportunity to learn it the first time. The good news is that there's no pharmacology. The bad news is there's a lot of new terms, and you've got to get the terms down. Okay, so anyways, back to pharmacology. I know it's a drag, but at least it's, you know, an easy drag. Okay, what I want you to know about aspirins. Okay, we've already talked that you're going to ask them, where's the pain, how intense is the pain, and then you're going to give them what they have coming to them by way of a doctor's order. You're going to come back the appropriate amount of time. Because if the medication is an intramuscular medication, you're going to come back in 20 minutes. If it's a PO medication, you're going to come back in about 35, 40 minutes. Okay? And ask them the same question. How is that pain? So if they reported the pain at 8, well, the second time around when you come in, you're hoping that they say a 3. Okay? If they're still saying an 8, you need to figure out why. Okay? It might be that you need to distract them. It might mean that they need to have something more powerful. You have to figure that out. That's your job. If they need something more powerful, you need to get on the phone and call the doctor and get something for breakthrough pain. Okay? Okay, and then, we talked about that we're going to do vital signs. You're going to do this anyways. That it can cause, it being the aspirin can cause GI upset, so you're going to give it with food. You're going to test them for aspirin poisoning. Okay. If they're having surgery, it says 1 week. I got to tell you, the literature in your book say 14 days. Decrease 1 week before and after surgery. I don't agree with that. If you find it in your book where it says 1 week, then I'll go with it. But honestly, the standard in medicine is 14 days. Then that's where we got into this. There are lab values, and these are the lab values. Okay, it's called PTT, prothrombin time, pre-timing, or prothrombin. Well, one of them is, I'll just leave it. It's PTT, because I don't know, and INR, international ratio. These three they are blood tests that are done to determine how quickly the person will clot. So when a person is going for surgery, they do this lab work because they want to make sure that if they cut into someone that they will clot. Does that not make sense? And so sometimes when we are giving Tylenol in excess, or not Tylenol, aspirin, excuse me, we want this information. Okay, now listen. If you are giving aspirin and an anticoagulant, that's a drug classification. The main drugs in that are heparin, which you learned how to give a heparin shot, and are warfarin. And we've talked about warfarin in this class. Another word for warfarin is Coumadin. Those are anticoagulants. Well, if you give one of those drugs and you're taking aspirin, it's a double whammy. It's going to drop these numbers. If these numbers get too low, the person will bleed to death internally. So, and remember how we said that you're going to, in the morning when you acknowledge your drugs, you're going to check the lab values specific to the drugs that you're giving. So if you are giving an anticoagulant, you need to check these labs. Or if you're giving a medication that has aspirin in it, you need to check these labs. Okay? Okay, then we talked about guaiacing stool. A hemocolt and a guaiacing, it's slang for the same thing. And what you are doing is taking a little smear of stool on a tongue blade, putting it on the little paper, putting some reagent on it. If it halos a blue halo, then it's positive for blood. The same thing that they do in CSI. You can't bleach blood away. Okay, you cannot bleach blood. And then we talked about Rye syndrome, and we said, I didn't say, but I'll say now, I said children initially, but anyone less than 22, you want to be skeptical about giving that person aspirin because Reye's syndrome can be deadly. Okay, so then you guys have all seen this scale. We talked about it in lab, skills lab. Patient teaching, okay. We've talked about all of this, right? If you have any aspirin poisoning, which is salicylism, okay, and there are the symptoms: tetanus, GI pain, nausea, vomiting, flushing, diaphoresis, which is excessive sweating, a headache, diarrhea, unusual bleeding or bruising. You should know your patients and know how easily they bruise. The older the person, typically the easier they bruise. Okay, and if they have dark stools, I know it sounds weird, but you tell your patients, don't flush the toilet, I want to see it. If it looks dark, then you want to guaiac it because you're looking for melanin, because melanin tells you that they're internally bleeding, and if they're internally bleeding, it might be because they're having too much aspirin and or anticoagulants. Okay, discard, buy in small amounts. Yeah, you know, I gotta tell you, your medicine cabinet should not, like when you open it, nothing should fall out. If something is falling out, you have too much in your medicine cabinet. You do not want to have pills hanging around. And you do not want your kids to think that, oh, I have a problem, take a pill. We live in a culture that is highly, highly addictive right now. And, you know, you don't want to go down that road and, you know, you be the psych tech for your kid. You know what I'm saying? That would be a drag. And so one way to prevent it, besides talking openly about it, is not having stuff hanging around the house. Any narcotics that you have, when you're done with them, they should be, okay, we're not supposed to flush them down the toilet, right? Because that gets into our water table. But you should take them back to CVS and have them dispose of them as pharmaceutical waste. Okay, discard the aspirin if they have a vinegar odor, keep in a tightly closed lid. Okay, we've already talked about the reason why there's cotton is because you can't get any moisture in those pills. Okay, avoid with other medications. I don't want to say avoid. Yes, I do. Avoid other medications with salicylates in them. You want to know, because I'm telling you that you can cause liver damage if you get too much aspirin. I've said that so far, but I have said more than 4 grams a day of Tylenol will throw the person into liver failure. You have to know that. That is entry-level knowledge, okay, for this field. Okay, discontinue use of meds 1 week before surgery. I have a problem with that. It should be 14 days. Okay, now we're leaving aspirin and we're going to Tylenol. Acetaminophen is the generic name for Tylenol. Tylenol is the trade name. So we have different, you know, brands that we can choose from. Most widely used aspirin substitute. So if someone is allergic to aspirin, or if they're younger than 22 years old, we're going to use Tylenol. Okay, if they experience GI upset with aspirin, maybe we want to use Tylenol. Maybe they have a bleeding disorder. Hemophiliac is a bleeding disorder. We've talked about it once. A hemophiliac is someone who has missing ingredients in their clotting cascade, and as a result, they don't clot. Okay, bummer to have hemophiliac's disease. Okay, literally, they can fall and bleed to death. Okay, drug of choice, okay, DOC, drug of choice for treatment of fever and flu in children. Okay, so it's a non-aspirin. Tylenol does not have aspirin in it. Okay, now listen to this. Aspirin is an anti-inflammatory. Tylenol is not. Okay? Okay. What does that mean? That means that aspirin is really good to reduce inflammation. Tylenol does not reduce inflammation. Okay? It is an antipyretic, so it will take a fever away. It is an analgesic, a non-narcotic. Okay, so we're going to use this for chronic pain. Okay, mild to moderate relief, temp, if you're allergic, and if for people who have hemophilia. Okay, I want to talk a little bit about ulcers here. Just give me a second. This is a prelude to what we're going to get deeper into in just a minute. And then we've already talked about hemophiliac and anticoagulant. I want to talk about ulcers. You have your stomach. Here's your esophagus. Here's a greater curvature, a lesser curvature, the pyloric region. The first coating in your stomach is a thin, I'm drawing this way to, here's your cardiac sphincter up here. The first layer, and it's only like 2 or 3, maybe 4 cells deep, is prostaglandins. That prostaglandin barrier protects your stomach from the hydrochloric acid. Have you ever thought, oh my gosh, this acid is super volatile, you know? It's pH of, -4 to 1 in the stomach. Why is that acid not eating the stomach? It's not eating the stomach because of this barrier, this prostaglandin barrier. Isn't it great that we have that? Okay, now, when you habituate antacids destroy the prostaglandin barrier, and then the hydrochloric acid can get up into the mucosa now and form a sore. And I shared with you that sore, that ulcer, is a liken to a decubitus, which is an ulcer on the outside of your body. It looks the same way on the inside of your body, in that the skin on the outside has been eaten away. Here, the mucosa on the inside has been eaten away. Do you see how serious that is? And it's even a bigger bummer. This is where food, when you eat, food hangs around in here, right? It's even a bigger bummer if that's where the ulcer's at, on the greater curvature. Okay, yeah.
So you're saying that if you eat food, okay, we eat some spicy food, like a lot of us like, I like spicy things, and I have and I take like a Pepsi or like what's the one that's pink?
Pepto-Bismol?
Pepto-Bismol, those are antacids, and
Yes.
that destroys the
Prostaglandin barrier of your stomach and leads to an ulcer.
So how do you combat against, if you know you like hot food, you like to put hot sauce and everything or whatever, then how do you,
Combat that?
yeah.
If you are habituating any over-the-counter drug, all it is doing is masking a bigger problem. And when you face it, have you heard, as an adult, problems hang around for decades? You know, you're a little kid, you throw sand, you get scolded, you go to the principal's office, what have you. At the end of the day, it's over. Well, when you become an adult, you do a problem, and it hangs around for decades. 4 decades. Part of the reason why I am trying to be such a good grandmother is that I feel like did I not do the best I could have with my kids? How did my kids not turn out and be picture perfect? I want to know that. It's not my fault. They're independent agents.
No, I didn't see your flaw. I said that's a flaw.
Oh, yeah, whatever. But I'm just telling you, so it hangs around forever, the problems.
So that's like they go so hard for their grandchildren.
Well, that's why I'm doing it. I mean, if truth be told, I'm doing it because I love them and it brings me a lot of joy. But I'm also doing it, I can't bear the thought of a generation slipping on my lineage. Okay? I can't bear that thought. So, I mean, I did the best I could with my kids. I don't hold myself responsible, but you know what? I really want to work at this generation. Okay? Yes, they're on their own, and if these grandkids do the same, they're on their own. But I want to know that I know that I know that I gave it my all, because that's how I feel good about myself. Okay, so how did that come into this? Okay, prostaglandins. Let me bring it back around. Another thing that destroys the prostaglandin barrier is alcohol. Did I not say if you put a drop on open mucosa, it will inflame and oozle and turn white and pink and start to drain a discharge? One drop. I don't care if it's beer, wine, or hard liquor. Did I not say that when you smoke, when you vape, when you bong, that it irritates the mucosa, and that's what happens, is that mucosa. So people make you think that it's okay and that it's fine, because at that moment it is fine. But when you habituate that for 20 years, it's not fine. And then when that prostaglandin barrier goes away, then that hydrochloric acid gets in there and it starts eroding until you have a hole there. And then now that blood is into your peritoneal cavity. Do you see? I gotta tell you, and we're just speaking off the record here, the worst death I ever saw was AIDS. AIDS is now a chronic disease. And so it doesn't have the death that it did in the 80s. I felt hopeless and helpless when I took care of those people. You can't do anything for them. The next worst is lung cancer. Lung cancer, you feel the same way. They just die this slow, agonizing death, and you're trying to help them as much as you can, and you can't. The next one is alcoholism. When someone dies of alcoholism, and the bummer about dying of alcoholism is that the whole family is fighting, and you're there. And if you're lucky if they're fighting, usually they don't show up because they've kind of forgotten about that person because they're so irritated with them for always being drunk and never being there. Okay? So anyways, that prostaglandin barrier is very important. That's what causes ulcers. That is why they GI bleed, is because it's eroding the mucosa and eventually it gets down into the vascular system of the stomach and they start to throw up blood or they poop it out. Okay? So that's what I want to say about ulcers so that you have a little bit more background as we go forward. Okay, adverse reactions, there's few with Tylenol. Okay, it's used chronic or high dosage, result in hives, blood disorders, hepatotoxicity, right here. And that can be the same as alcoholism, okay? Your hepatic failure taken by chronic alcoholics. Okay, now, right here, 10 to 15 grams is they're saying is the toxic level for Tylenol. I'm telling you 4 grams. So we need to find out what the book says, because your state board test, so I will take the responsibility for that. I have never, in all the literature I have read, and I've done a lot of reading in my lifetime, it's always been 4 grams of Tylenol will cause liver failure. Do you have something, George? Did you look it up? Or?
I was gonna ask what chapter is this part? I didn't look it up.
I'd have to look. I don't know off the top of my head. Okay, but anyway, so signs of toxicity are, and here they are: nausea, vomiting, confusion, liver tenderness. When you touch your liver, you should be able to feel it. It goes about maybe 2 inches below your last rib, at the most 2 inches, I should say. And there should be no tenderness there. Hypotension can cause arrhythmias. Jaundice we've talked about, right? The yellowing of the skin and of the sclera of the eye. Here you go, sir. Okay, so these are the nursing responsibilities, and we're again talking about Tylenol. Okay, so non-narcotic, okay, analgesics, non-steroidal anti-inflammatories, NSAIDs. More than 70 drugs, anti-inflammatory, antipyretic, and they're analgesic, and here we have some listed. Okay, now I want to, this is the toughest part that we're going to talk about today, but it's not bad, okay? There are COX-1 and COX-2 enzymes. Both of these produce prostaglandins, okay? However, only COX-1 produces prostaglandins that activate platelets. Okay, so we want to give COX-2, it's a further generation. Oh, excuse me, we want to give COX-1 because that's the one that protects the stomach and intestinal lining so that we won't go into an ulcer, okay? So we don't want to give COX-2. NSAIDs block COX enzymes and reduce production of prostaglandins. Therefore, inflammation, pain, and fever are reduced by all COX inhibitors. Since the prostaglandins that protect the stomach and promote blood clotting also are reduced, NSAIDs can cause ulcers in the stomach and intestines and increase the risk of bleeding. You all know that now, right? You feel comfortable with that? That's the bummer about going to your medicine cabinet. One of the bummers. Unlike other NSAIDs that block both COX-1 and COX-2, the newer COX-2 inhibitors only block the COX-2 enzyme. Since COX-2 inhibitors do not block COX-1, which primarily produce prostaglandins that protect the stomach and promote blood clotting, they do not cause ulcers. So the takeaway home story is, if you are going to take Tylenol, you want to take a COX-2 Tylenol, NSAID. Okay, so let's hold on with me. Okay, COX-2 inhibitors are as effective as other NSAIDs for treating inflammation, pain, and fever. Celecoxib is the only COX-2 inhibitor currently available in the United States. Okay, these other Vivanox, Vetra are no longer available because they increase the risk of heart attacks and strokes with long-term use. Okay, and they were discontinued. Do you not see the web that is being created here? So they came out with these COX-2 and they thought that that was the miracle drug. Oh my gosh, now we don't have to worry about the prostaglandin barrier of the stomach. Oh my gosh, we don't have to worry about ulcers. Oh my gosh, we don't have to worry about GI bleeds. Oh, now we have to worry about heart attacks. Oh, okay, one's deadly, instantly. The other is kind of a long, agonizing death. Okay, let's take our choice. Which one do you want? Do you see where I'm going with this? Okay, so they inhibit prostaglandins, ibuprofen, naproxen, cause GI reactions. Celebrex and Vivanox have less potential. They relieve the symptoms of arthritis, musculoskeletal disorders, moderate to mild pain, or mild to moderate pain, I should say, dysmenorrhea, difficulty, that's menstrual cramps, dysmenorrhea. Urea, like diarrhea, means to flow. Men, M-E-N, in Latin means month. So this is the monthly flow that a woman has. And then dys means painful. Okay, adverse reaction, GI tract, CNS, blood disorders, prolonged, we've talked about this. Caution with elderly, everything is a caution with elderly. During pregnancy and lactation, lactation means if the mother is nursing. excreting milk from her mammillary glands to feed a child, and increased risk of bleeding when taken with anticoagulants. Okay, yes, we'd want to do vital signs, especially if we're giving it for an antipyretic value. Yes, we want to give food if it causes GI upset. Yes, we always want to assess the joints if that's the reason why we're giving it. Did you find the answer, George?
Yeah, so toxicity comes to 10 to 15 grams. And doses that we people is 20 to 25 grams.
Say that louder.
So doses that are,
Sorry.
doses of toxicity or toxicity can occur after a single 10 to 15 grams dose of acetaminophen. I can't totally finish that word. But yeah, 10 to 15.
Okay, so it's 10 to 15. Okay, I have always read 4 grams. So that's quite a bit of difference. Okay, so I would say for your state boards, go with the 10 to 15 grams, but out there in the real world, I'm telling you here and now, it's 4 grams.
Yeah, probably depends on body weight.
Yeah, I mean, it does, but 4 grams is not very much. And 4 grams, you can avoid that daily, absolutely. But if you're taking a lot, and this is the take-home message that I want you to hear, other medications have Tylenol and aspirin in them. So you need to read the label and see what it has and how much it has in it, and it will tell you the milligrams, and make sure that your patient stays way below 4 grams, but remember 10 to 15 for your state boards.
Okay, range of motion, apply splints, and we're talking about why. We're talking about arthritis, and we don't want them to have contractures. Record and report all side effects to the primary health care provider. You do guayaking, check the PT, and we've talked about all of this. Okay, this is really good, this lower one, to prevent foot drop that we've talked about. Same thing that a high top tennis shoe would do. This one up here is preventing the fingers from getting all contracted. Okay, now this is our last subject that we're going to talk about today. And we're going to talk about narcotic. Oh, yes, we can get this done in 15 minutes. I feel so good. Okay, now we're leaving aspirin we talked about. And we talked about Tylenol, okay, that COX 1 and COX 2. And then we are now talking about narcotic, okay, narcotic analgesics. Okay, acute pain is a warning that something's not right. What drives most people to the emergency room? It's pain. That's what takes most people to the emergency room, okay? So it's a warning, something's not going right. Chronic pain will persist for a longer period of time, and usually chronic pain becomes just that. The person has to learn to live with it, deal with it, cope with it, because it's always underlining going to be a part of their life. Opioids, analgesics obtained from opium plant, okay, are a type of narcotic. Morphine and codeine are a type of narcotic. Dilaudid, heroin, Demerol, methadone. These are all examples. Okay. Morphine is thought to be the most potent narcotic. It is not. Dilaudid is 7.5 times more efficacious, more potent than morphine. Okay. Fentanyl makes Dilaudid look like it's a baby. Okay. What's on the streets right now. Demerol is kind of, blasé. Methadone, I never really understood this. They give methadone when a person is addicted to heroin. They're both in the same drug classification. So you take one dependency and you flip it over to another. Okay, let's talk a little bit about pain. I just want you to, when you have a pain
this is the pain receptor. This is signaling to your brain that this is the receptor that is going to be in between the nerve endings, the synapses, right? That says pain, 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 pain. When you take a narcotic and it has the opposite, so that it becomes a mirror, it becomes symmetrical, right? Then the theory states that you cannot become addicted. So if you have something that can receive the pain medication, their addiction will not follow. But then if you have a lot of narcotic floating around and there's no receptor for it, so here's the narcotic floating around, and here's the receptor. There's no place for it to go into. That person will become addicted. It is the person that has narcotics circling and circling and circling that becomes addicted. Okay? So what happens is these narcotics, these analgesics that we're talking about, bind to a pain receptor. Morphine is the most widely used opioid and effective drug. Codeine is used to treat moderate or mild to moderate and a persistent cough. We talked about that. Codeine is one of those few drugs that will work on the pons where the cough center is. To lessen anxiety and sedate before surgery. Absolutely. You take a narcotic and, nothing in the world matters. Just everything is just, it's almost like they're on an anesthetic. They just kind of float through la-la land. It's used to support anesthesia. People are uptight before they go to surgery. What's the outcome? What's going on? My thoughts are is if you're that uptight, don't have the surgery. Come to grips with it. But that's not, this is a chemism, when money's involved, if they can shut you up, it's a lot easier. And that's why you and me and all of us need to critically think, right? You know what's best for you, do you not? You know when you lie, do you not? You know all of these things. That was given to you at the age of reckoning. And at the age of reckoning, we all know what we should be doing. Now, some of us will take the lazy path, and you know what? We'll pay dearly for it. If you take the lazy path, you will pay. And like I said to my kids, even street people work. But they have to work at finding a place to sleep. They have to work at finding food. But they still work just as hard as we do, doing all of that. Wouldn't you rather have worked this hard and have that taken care of? And have a nice place to sleep to boot? And not have to worry about rats and mice and fleas and wood ticks and ants and all of that where you lay your head down? They're still working. But they have to work and worry about all of this. Okay, that's another big thing, that. But anyways, we know that most mental illness is caused by addiction. And that's not a chemism, that's science. Okay, so the narcotics are also relieve myocardial infarction. Okay, when you have a myocardial infarction, a heart attack, your heart, because the coronary arteries have gotten thin, they have vasoconstricted. Morphine will open them up and cause more oxygenation to the heart. So morphine is the drug of choice for a heart attack. Management of opiate dependence and treatment of severe diarrhea. Management of opioid dependence, here we have the methadone and the Suboxone. Detox is withdrawing from the narcotic from the patient while preventing withdrawal symptoms. The bummer about opioids is that they are highly, highly psychologically and physically addictive. And if the blood level is not maintained, the person will go into seizures and die. Not just a seizure,
but like a major grand mal seizure and die. Okay, that's the bummer of these drugs. And what's even weirder is that people are paying money to be on these drugs and they're acting as normal as you and I are once they get addicted. Okay, maintenance treatment is designed to reduce a patient's desired dosage vary. Should wear ID bracelets. Okay, adverse reaction. Okay, I say narcotic, what do you think? O'Neill? Respiratory, thank you. It decreases both the rate and the depth. Those are two different centers in the pons that control respirations. And this is what people like about it. They like that dizzy, sedated, lightheaded feeling that they get. Mental clouding, and that clouding, it's like, oh, mañana, oh, whatever, no big deal. They get dry mouth, bladder spasms, and it can cause tachycardia and bradycardia. Okay, precautions and contraindications. I just want to see where we are. Okay, I have about 6 more slides and we're done, okay? Can you guys hold out for 6 more slides, or?
Yeah.
Okay. Where are we? It is 10:54. I'm gonna do 3 slides and let you go, okay? So, why would you not give narcotics? Okay, if they have an allergy towards, if they have bronchial asthma, if they have emphysema. Do you see how all of these things are already affecting the rate and depth of respirations? And then you give a narcotic on top of it. It's like getting a double whammy. Upper airway obstruction, head injury, seizure disorders. When you get a head injury, your because the pons, the lower part of your brain, is where the respiratory centers are, okay? Precautions during labor and delivery. Why? Because the baby takes on anything before 6 centimeters. Labor is long and laborious. We've all heard it, right? We've heard of the woman in labor for 48 hours, okay? It takes her forever to get to about 6, 7, and then she goes like crazy from 8 to 10 and pops out that kid. So it's a lot of waiting. Then all of a sudden, boom, she hits 8. Wake up, get in there. This baby's coming. Okay, so if you give a narcotic up until about 7 centimeters, 1 to 7, yeah, the baby gets it, but it's gonna be worn off time the baby's delivered. If you give it at 8 centimeters, the baby's gonna be pretty well delivered really quickly, so the baby's gonna be born high. When the baby is born high, it doesn't want to breathe. You need to breathe, right? It's learning how to breathe. It doesn't know really how to breathe. But so now you've taken something that's counteracted it from wanting to learn. That's the problem right there. Okay, taking alcohol, antihistamine, sedatives, phenothiazide, anti-MAOs, you'll talk more about that in your education, okay? So when you're taking these drugs, this is not the time, because all of these drugs right here decrease the respiratory rate. You don't want to have a double whammy. So you want to know, do they have any allergies? What are they taking over the counter? All narcotics are double locked and followed protocol for accountability. I'm going to stop here because this is too important to ramrod through, okay? This double locked, you've got to know this. This is entry level knowledge, and there is incredible accountability on you for giving narcotics, okay? And it's something that should be taken very seriously. So we're going to stop here. It is 10:57, although none of the clocks in here I have learned are accurate, but now they are. Okay, so you guys, thank you. We'll finish this up on Wednesday, and I will give you the dates tomorrow for when ultimately the homework is due, okay?
I don't know either.
Yeah, right. Give me your I work.
You wanna send me a little bit?
No,
Yeah, most guys don't.
How was your growth program?
And that was our